Thanks a lot, Dan. Good morning, everyone. It's my great privilege today to introduce Dr. Nils Johnson, who is our grand round speaker. Dr. Johnson is an expert in coronary physiology, and really we wish we would have had him in November for our fellows debate, which was at the cross section of invasive coronary physiology and PET perfusion imaging. So Dr. Johnson completed his undergraduate degree at the University of British Columbia in Vancouver. And then he came over to the East Coast and went to medical school in Columbia University in New York. And after that, he was at Northwestern University for the rest of his training in internal medicine, cardiology, and then interventional cardiology. And he overlapped with Judy Meadows at that time. He then also pursued a Master of Science in Epidemiology and Biostatistics at Northwestern, and then started his career in coronary physiology with Dr. Kay Lance Gold at the Weatherhead Pet Center at the University of Texas. And since then, he's been a world expert in coronary physiology. He's been the principal investigator on numerous trials in coronary physiology, most notably the contrast trial looking at contrast FFR, and then the defined flow study looking at FFR in coronary flow reserve. I've continued to follow his career for a number of years. I first saw him talk at the Coronary Physiology Conference in 2016, and I've just been amazed by his body of work, and I'm really looking forward to this talk today.
Well, Dr. Shah, thank you so much for the introduction. Good morning, everyone. Greetings from Houston. No snow here. It's foggy outside. I think it's going to get up into the 70s today or something like that, ridiculous. So, but as you've heard, snow is not unfamiliar to me, having lived in many different places. So I wanted to first mention these are the disclosures. I'm going to be talking about a little bit of software that we've developed on our side to implement some of the concepts. We don't make any money off of it, obviously, but it's something that the institution has. So as you maybe got a flavor of from Dr. Shah's introduction, my career has largely been focused on trying to be a bridge between two worlds of looking at physiology, the cardiac PET lab where we do perfusion imaging, quantitative perfusion imaging, and the cath lab where we make invasive pressure and flow measurements. And I don't really consider myself a PET guy or a cath guy. I'm really an applied physiologist. And it just so happens that some of the best tools that I think we have in cardiology to understand physiology are cardiac PET and invasive pressure and flow measurements. And that really then is a bridge to making accurate clinical diagnoses as a means to select treatment and monitor response to therapy. And so what I wanted to talk about were a couple clinical cases at the beginning that I think will set the stage for then discussing a variety of pathophysiology and kind of linking it then up at the end with treatment. And so I'm going to show you these cases, and they're just bits of teasers. I'm not going to give you the answers yet. We'll work through some of the background, and then by the time we circle back at the end to them, I think you'll understand exactly what's going on with these. So the first case is a 68-year-old woman who has angina. It's been going on for several years. She does have some LV hypertrophy, is obese, normal ejection fraction, no major valve disease, and was actually cathed about a year previously. You can see the coronary angiogram down at the bottom. Didn't do FFR, but it would have been normal in this particular case. And she came to us for evaluation and had a PET scan, which you can see the rest and stress perfusion images up at the top. And she had really severe angina with diprotomol. And the question then is, why is this happening? Why is she having angina dyspnea? Why did she develop such a severe symptoms during diprotomol vasodilator stress, right? The next case is a 77-year-old woman who came in with an NSTEMI, probably just myocardial injury, actually. She had some dynamic troponins that were noted during gallbladder surgery, and as a result underwent invasive coronary angiography, which just showed some mild coronary disease. Again, normal EF, some mild aortic sclerosis, came to us for a PET evaluation, and during diprotomol had really severe angina and marked ST segment depression, up to 2 millimeters ST segment depression. You can see her perfusion images up top, both the rest and then the stress. And again, not so eye-catching for a huge obvious defect that would explain all of this. And so we left with the question again, why is this happening for this particular patient? So that's a bit of the clinical scenario that we're going to try to answer today by thinking through the pathophysiology largely of the subendocardium. And I want to talk about the subendocardium and how it's different. In a way, it's the forgotten layer of the myocardium. This is some very old animal data from my mentor here, Lance Gould, back when he was doing some of the original perfusion studies linking epicardial stenosis to myocardial perfusion, in this case doing cross-sectional tomographic imaging post-mortem in an animal model. And you can see that he's put a stenosis there in the circumflex vessel and then injected radioactive tracer. And the septal wall, which is normally perfused, of course, if you look at the cross section, has very flat perfusion from subepicardium to subendocardium. And the lateral wall, then, which is fed by the stenotic circumflex, has a perfusion defect. But when you look at how this perfusion defect displays itself in cross section, you see that it's not equal. You can see that the subepicardium is reduced, but it's not reduced anywhere as near as the perfusion reduction to the subendocardium. And of course, it's important for us to understand why this is. Why is the subendocardium so uniquely sensitive? And the reason for this is that the various layers of the myocardium are subject to very different mechanical forces. Of course, during diastole, the LV filling pressure is low, and there's really a low pressure gradient across the entire wall of the myocardium. And therefore, you really get adequate perfusion to every single layer, the subepicardium, the middle, the subendocardium. However, during systole, that changes dramatically. The subepicardial layers are still just subject to the pericardial thoracic pressures, whereas the LV cavity then during systole has an enormous increase in pressure up to whatever your systolic blood pressure happens to be. And as you can see in the figure in the lower left, this results in a redistribution, if you will, or a cessation of flow to the subendocardial layer, redistributing to the middle or even to the subepicardial layer. And as a result of that, then, the subepicardium is really uniquely sensitive to changes in pathology. And I'd like to make an analogy. And the analogy is if you were, say, an alien or something, you came down, you landed here, and you looked at the flow of money. Let's say you're interested in money perfusion. And you said, all right, we're going to look at the United States and we'll see how much money is flowing in. You can see the number here for 2019. So, all right, a little over 300 million people in the US. Therefore, the perfusion to each person in the US has to be about $65,000. Each one of us should get $65,000 a year. But of course, we understand that's not the case, right? We have people like Zuckerberg and Gates who get an enormous amount of money, and I'm sure you've seen some people who had much less than that. And so it's not that there's a inadequacy of flow so much as an inadequacy of maldistribution. And it's the same thing actually to the myocardium. So you can do a very similar calculation where you say, all right, there's about 5 liters of cardiac output. It goes up with exercise. The heart gets a certain fraction of cardiac output. There's maybe 300 grams of myocardium. Hey, listen, there can't be ischemia, right? Because the coronary flow should be then 3 cc's per minute per gram. But again, it's a maldistribution issue, and the subendocardium gets less. And this is something that's been long appreciated. This is some work that was done back by some people who I'll be talking about a fair amount, Julian Hoffman and Gary Buckberg, who did the work back in the 1970s looking at subendocardial maldistribution. And as you can see, this decrease in flow to the subendocardium can often be compensated for by increased flow to the subepicardial layer. And so if you only look at total coronary blood flow, it really gives very limited information. And the reason it gives limited information is because of this effect of maldistribution, right? There's trickle-down economics that also have a role to say in the myocardium. So what they came up with then in the 1970s was a way of trying to quantify 2 competing issues. One, of course, is myocardial demand, and the other is coronary supply. And they developed this ratio of supply to demand, and it's something that is straightforward to explain graphically. You can see here that the systolic pressure time integral, that's what SPTI means, is a measure of demand. It's the area under the left ventricular curve during systole. The larger that is with hypertension and other forces we'll talk about, the more the demand on the myocardium. And that is balanced then by the diastolic pressure time integral, the DPTI, which is the area then between the aortic and left ventricular curves. And it's a measure of how much potential blood flow then can happen during the diastolic period when, as you can see down at the bottom, the majority of coronary blood flow occurs. And by taking this ratio, as we'll see, it's an important way for understanding how this trade-off changes under various clinical circumstances and how we can think about the therapies that we use to treat patients' symptoms. What's interesting too is that this ratio, while largely balanced, under conditions of pathology becomes imbalanced, and that ends up affecting the subendocardium directly. This is a kind of an aggregate of many different studies that they did over the years, looking at various pathological conditions, as you can see in the legend. And when that epi-endo ratio, that is the supply-demand ratio, is quite high, there's a balance. The subendocardium receives just an adequate blood supply with the subepicardium. But once you cross a certain threshold, and again, I don't want to get into the specific numbers here because it largely derived from animal data, and I think the concept is much more useful. Once you cross this threshold, that's when the imbalance begins to occur. That's when maldistribution happens. And as you can see, there's a direct drop off then in perfusion to the subendocardium, especially. That's the area that is uniquely sensitive to all of this. So let's look at this notion then in a couple of examples they presented. On the very left-hand side here is a normal patient, well, not completely normal, has an atrial septal defect, but fairly normal, I guess you could say. And I've highlighted the areas then of systolic demand under the curve in red, and then the area in blue for diastolic supply. And you can see the ratio is quite large, and so you can understand that this patient is able to perfuse all of his myocardium successfully. Contrast that then with the tracing in the middle. This is a patient who has aortic stenosis, and these measurements were taken under resting conditions. Of course, systolic demand is much higher because of the gradient across the valve, as you can see in red. And in this particular patient, aortic stenosis has also elevated LV filling pressures, and you can see that that combined with the heart rate already serves to make diastolic supply much lower in comparison to the normal ASD patient. What's interesting too in this case is they took that AS patient and infused isoproterenol, which is a medicine, of course, that increases heart rate. And you can see that two things happen. One is that demand increases because the gradient across the valve gets larger, but then also tachycardia and increases in LV filling pressure serve to further reduce the blue area of diastole. And so that imbalance then shifts even further. And in this particular case, they were able to measure then lactate production in this patient because the balance had tipped from being able to supply the subendocardium successfully to having frank subendocardial ischemia. So you say, all right, that's great. So the subendocardium, I get it. It's uniquely sensitive. Trickle-down economics don't always get supply to the subendocardium the way that they should. Do we have to make these complex pressure measurements all the time, or is there a way that we can potentially image this? And imaging the subendocardium is something that's been going on for a long time in cardiac PET, which is my particular area of focus and what I'd like to talk about today. As though if you look in the literature, this is also something that cardiac MRI has a good ability to do as well. This is some work from about a decade ago now, looking at just a simplistic model of taking the myocardium, dividing it into an inner subendo layer and an outer subepi layer. And as you can see in this particular group of patients, these are healthy volunteers, about 30 of them or so, the balance is fairly good both under rest and stress conditions, as would be expected because the subendocardium is able to receive adequate blood supply when there's no pathology around. This then is looking at that same kind of notion, something they call the transmyocardial perfusion gradient, which is largely a measure of the imbalance between the subepi and subendocardiums. And under baseline conditions in this cohort of patients who had coronary disease, again, largely balanced. You can see the ratios in blue are fairly close to 1. However, under conditions of hyperemia, that's when the pathology develops. And you can see that ratio falls below 1, and especially in patients who have a significant epicardial lesion identified by a low FFR value, that value can be quite significantly low. What I find most interesting, though, about this data set is the real scatter, that is the heterogeneity among humans, among patients, and how well they can maldistribute or not. And this is a scatter plot looking then at fractional flow reserve, a measure of epicardial pressure loss due to coronary disease. And then on the y-axis, the transmyocardial perfusion gradient, that is the imbalance between endocardial and epicardial flow. And I've highlighted two patients here who have quite similar FFR values. If you just made epicardial measurements, you might say, well, these patients must be quite similar then. But you notice that the patient in blue up at the top does not have transmyocardial maldistribution, whereas the patient at the bottom did. And so this highlights an issue that simply making epicardial measurements doesn't give us complete information about how blood flow then is distributed across the wall of the myocardium. And so what I'd like to show you now is how we here have started to develop some software in order to quantify and look at this in a little bit more detail. What we do is we take the PET images and we put them into short axis views, you can see, and then we sweep out a series of radial segments. And among each radial segment, what we identify are 3 key points. The 2 green dots, as you can see, are the endocardial and epicardial boundaries. And then the red dot is the area of maximal activity. And so we do this all the way around the clock for 64 radial segments. The maximum activity then is what we use to plot our standard topographic maps. This is like taking a kind of the surface of the earth, right, and then wrapping it as you would a map that way. And this is what we use to measure our rest and stress activity, as well as quantitative flow and cc's per minute per gram, as well as coronary flow reserve that we integrate into a single metric called coronary flow capacity. However, for the rays themselves, what we're able to do is something a little bit more sophisticated. I'm showing that over here on the right-hand side. This is a single cross-sectional image for a patient on the left-hand side under rest conditions and on the right-hand side under stress conditions. And you can see a single ray here with this blue line. That's the profile is shown down here at the bottom of activity across the myocardial wall under rest conditions. And then the red line is the same thing at the exact same ray location under stress conditions. And the subepicardial outline is in white. You can see how that's different for each of the 2 images, but the subendocardial border at rest has been copied over onto the stress images. And you can see here visually that there's a defect then in the subendocardial region over here at about 4 o'clock or something like that. And when you look down at the bottom, then this is something that's also been quantified with 2 different metrics that we've developed that have proven to be the most powerful for quantifying this. One is a measure of the stress endo-epi ratio. That's if you take the stress images alone, just the red curve, divide it in half and take the ratio of these 2 areas, the up slanted lines and the down slanted lines. Again, that area should be approximately 1 if there's equal perfusion to the subendo and subepicardium. And then the other metric is the endocardial stress rest ratio, which is if you take the blue curve and divide it in half and take the innermost endocardial ratio, the little dotted area under blue, to the little dotted area under the red curve. Again, a metric that should be 1 if there's equal perfusion under rest and stress conditions to the subendocardium. And these are metrics that then we have a fairly large cohort of normal volunteers, people who are under 40 and had no risk factors, that we were able then to select normal thresholds for both of these. And based on that, then we're able to quantify the percentage of the myocardium that has abnormal subendocardial perfusion. So now that we have a toolkit for imaging this, let's think a little bit about clinical scenarios and try to understand how often angina happens and what kind of clinical outcomes occur in that group. And I'd like to start off with what I think most of us have in our minds as the kind of poster child for angina. This is a 74-year-old gentleman whom I took care of in the past, had known coronary disease, had a distant PCI of his RCA, and developed fairly classic anginal symptoms. Came for a PET study, had a normal ejection fraction and fairly normal resting images. As you can see here, rest is the top of the 2 pairs, stress is the bottom of the 2 pairs. If you look over here, fairly normal resting perfusion images, but with stress, a large severe perfusion defect in the inferior infralateral regions. And in his particular case, we quantified myocardial blood flow, absolutely. And in coronary flow capacity, you can see that this area down here that's colored blue not only is severely reduced, but actually has myocardial steal. That is, this is collateral dependent myocardium. During adenosine, he had not only moderate angina, but also fairly significant ST segment depression, as you can see over here on the 2 EKG excerpts. Took him for angiography. You can see this really high-grade subtotal stenosis in the mid-RCA. I was able to successfully reperfuse the vessel and brought him back out of interest's sake about 11 months later, and just wanted to show you then the comparison of the stress images on top here before PCI versus the stress images here at the bottom afterwards. You can see an enormous perfusion and relative uptake. But also here's the coronary flow capacity maps over on the right-hand side in this area of severely reduced myocardial perfusion with myocardial steal has now resolved completely, and he has excellent flow capacity throughout the myocardium. And his angina resolved too. So this, I think, is what we often imagine the mechanism is for angina. And this indeed is a very strong reason that patients develop symptoms. So what I'm showing you here, and I'm going to go through then, are the different branches of this tree. I took all of our quantitative PET studies. We've been doing this now for maybe 13 years. We've quantified every flow case that we've got, about 8,500 or so studies in our database. I got rid of the ones, we do some research stuff for patients who had residual caffeine, or we're looking at various other stressors than dipridamol. And so we ended up with about 7,000 dipridamol scans. And of that, approximately a third have abnormal uptake images, by which I mean at least 5% of the LV has a relative uptake less than 60%. And so I've grouped them into a couple categories here, depending on whether it was pure ischemia or whether there was evidence of infarction or infarct only or the other possibilities. And like the patient that I showed, patients who have a completely reversible perfusion defect from rest distress images, like the example, have a dipridamol-induced angina or ST segment changes in about 42%. So it's a minority, but it's a big minority. And that then is explains, I think, what happens in that particular group of patients. Well, it turns out that, as you can see, is only about a third of our world. So we need to think about the other 2/3 where uptake images are relatively normal. And this is an example of one of those, a 56-year-old man who had marked angina, had been progressive over the last several months. He had poorly controlled risk factors, and I put him on a treadmill, and he was able to do just over 5 minutes before I stopped him. He really had limiting angina, just couldn't go any further. ST segment changes and a fall in blood pressure, right? How often do we see all of those high-risk features all at the same time? Interestingly enough, had normal gated ejection fraction. When you look at his uptake images, yeah, maybe there's a small little stress-induced defect here at the apex, but wow, could that really explain all of these things that was happening to him? His uptake images, not too dramatic, but yet if you look at his coronary flow capacity map, it's very just diffusely reduced, and there's large segments here of green, which is moderately reduced coronary flow capacity that accounts for about a quarter of his left ventricle. And you can see here during vasodilator stress, he had borderline ST segment changes, but also moderate angina with dipridamol. And when you look at his subendo maps, you can see that about 5 or 10% of his myocardium shells out, as you can see here on those cross-sectional images. Went on to have cath and actually had fairly severe triple vessel disease, and so underwent bypass surgery. And this is the type of patient who falls into this subgroup. Although 2/3 of the scans we have normal uptake, of that 2/3, maybe about 5% ends up having pretty severely reduced coronary flow capacity, like the example I showed where it's green for a large chunk of the myocardium. Almost all of those patients shell out, that is, they have subendocardial hyperperfusion, and dipridamol-induced angina or ST segment changes are common. Not as common, of course, as the ischemic example as I showed you at the beginning, but nevertheless, 16% of those patients have DIPI-induced changes. Let's take a look at another example. This is a 74-year-old woman who has known coronary disease, prior stents to the left coronary artery system. She's obese, a BMI of 32, and has some exertional dyspnea. And so the question is it restenosis, developed new coronary disease? Why is this happening in her particular case? And so she came for a PET scan. And again, you see relative uptake images that are fairly bland, no obvious large severe perfusion defect. The topographic maps over the right-hand side confirm that. And in her case, it's just a very diffusely reduced coronary flow reserve. You can see that the global CFR is 1.8. We test everybody for caffeine just to make sure that it wasn't blunted through inability of the dipridamol stress to take effect, and that's not the case here. But yet she had moderate angina during dipridamol and fairly significant ST segment depression. And when you look at her case too, there's no subendocardial perfusion defect. So this type of patient is the unusual example of someone who has true microvascular angina. Again, when we look at our own database of the 2/3 of patients who have normal uptake images, about a quarter or so have this yellow coronary flow reserve that is diffusely reduced coronary flow capacity. And patients like her who have no subendocardial hypoperfusion, maybe about 5% of them or so have dipridamol-induced angina or ST segment changes. Again, another example to flesh out this tree that I'm developing of categories. This is a 61-year-old man who again had known coronary disease with prior stents to the left coronary artery system, who came in with exertional dyspnea, as well as some resting pain. You can see normal ejection fraction And again, relative uptake images that are fairly bland, no large obvious segmental perfusion defect, and really excellent coronary flow capacity. You can see here that his global coronary flow reserve was 2.9, and the coronary flow capacity map is really all red. And yet we have to explain then why he had severe angina and marked ST segment changes during diapridamol. And the answer in his case comes from the subendocardial maps. This is the endo-epi map that I was showing you earlier. You can see here on the left-hand side the extent of the LV cavity under resting conditions. And with stress, look at this fairly sizable 360-degree circumferential area of subendocardial hypoperfusion, such that really the whole area drops out. This, although he has great flow to the other parts of the myocardium, this is the area that's suffering, right? So this is the United States, if you will. Great blood flows coming in, it just distributed to the wrong places. And so trickle-down economics didn't work for this patient either. And that's where his angina and ST segments are coming from. And this, in his case, is the mechanism that explains his angina. If you look again at our tree of the 2/3 of patients who have normal uptake, about 70 or so percent of them have very reasonable or actually excellent coronary flow capacities. The vast majority of those patients develop subendocardial hyperperfusion, and a small minority of those have ST segment changes or angina during diapridamol stress, like the example that I just showed you. So when you look at this tree, what I want to then do is flip it around a little bit. I've shown you these different branches. I've shown you how often patients fall into these categories and how often diapridamol induces angina or ST segment changes. But let's look at it as a dose response curve, for how much of the ventricle is affected by these mechanisms, and as a result, how much angina then is associated with it. So on the x-axis is the percentage of the ventricle that's affected by these various metrics. And on the y-axis is the amount of angina or ST segment depression in each category. And the light blue line here is the first person I showed you who had the RCA lesion, right? Large, big, bad blue perfusion defect that's very obvious. This is kind of our classic intuition for what we think causes angina. Here you can see that this is the strongest associator with angina or ST segment changes. And yet the minority of patients have it until you really get above maybe 15 to 20% of the LV. So patients are actually able to tolerate up to 10, 15 or so percent of the LV with a blue coronary flow capacity and not have these symptoms with diapridamol stress, but a fairly marked curve. And I think this is what we often think of as the mechanism for angina in our patients. However, like the other examples I showed you, there are these other weaker predictors, such as subendocardial hypoperfusion metrics, which I've shown here in 3 different flavors. 2 of them come off of the maps that I showed, those different ways of quantifying the amount of subendocardial shell out. Yes, again, a dose response curve. Once you get over here to maybe a quarter or a fifth or so of the LV, maybe about 1 out of 5 patients will have diapridamol associated changes in those settings. But still, it remains a minority. It remains a minority. And not only does it remain a minority, but it turns out the prognosis is quite good. So on this earlier graph, it was a dose response curve for how much angina happens. And on this next curve, it's the same metrics, the same percent of the LV, but now on the y-axis, it's death, MI, stroke, or revascularization. So clinical outcomes. In our database, again, it's about 13 years that we've been doing this. So we have average follow-up for 5 or 7 years or something like that in our cohort. Again, the strongest predictor associated with those subsequent bad outcomes is really transmural ischemia, the blue coronary flow capacity in a large section of the LV. Whereas patients who have these other subendocardial metrics do relatively well, especially compared to their counterparts over here. I want to take a little bit of time to emphasize that this isn't simply a diapridamol-induced stunning effect. You probably have seen cases where diapridamol, especially in the setting of very severe coronary disease, can actually induce LV dysfunction and dilatation. You might say, well, maybe that's the mechanism for this apparent subendocardial shell that we see. And that largely is not the case. And I'm showing that to you here by showing you the ejection fractions in each of these categories that are relatively intact and also augment as expected with vasodilator stress. So it's not like a stunning issue that happens in some rare patients. The second point I'd like to make off of this is that when we talk about microvascular angina, which is getting a lot of attention, this is actually a very uncommon reason for patients to develop angina or ST segment changes. You can see that patients who have reduced coronary flow capacity, either blue, green, or yellow, the number of those who don't have subendocardial perfusion defects but yet have symptoms is quite small. There are only about 6 in our massive database. And so microvascular angina certainly does exist, but it's a very rare entity, actually. Furthermore, you can see that patients who have really good coronary flow capacity and no subendocardial perfusion defect, again, rare patients in this category develop a departmental-induced angina or ST segment changes and have no obvious flow mechanism for that. That is, angina or ST segment change in the setting of diaprodemol can largely be explained through transmural malperfusion, like the ischemia example I showed you at the beginning, or through subendocardial perfusion problems, like some of the other examples I showed you. Microvascular and non-flow mechanisms are actually very uncommon. And so while they do exist, and perhaps we see them at tertiary referral centers, in the larger population, it's they're kind of zebras, if you will. So the last section, now that I've talked to you about the subendocardium, how we can image it, I've shown you some examples and how often it associates with angina and clinical outcomes. Of course, the practical question is, how should we treat these patients when we do see them? And I think this is an important opportunity to go back to this framework that Buckberg and Hoffman showed us about the supply-demand balance, and think really critically about ways that pathology modifies it and how our treatments then can undo that to the extent that it's possible. And so conceptually, then, when we think about the area under the systolic pressure curve, the demand portion of this, it can be driven up, of course, through largely outflow tract obstruction, right? Either the body's hypertensive or there's a problem in the outflow tract itself, like aortic stenosis or hypertrophic cardiomyopathy. On the flip side, then, the diastolic supply part of things can be affected through tachycardia, through coronary artery disease, largely atherosclerosis, but also in some patients spasm, and also through changes in LV filling pressures. And so what I'd like to do is to go through each one of these mechanisms, to show you some conceptual examples and talk about how treatments can be related to it. So when we think about decreased supply due to increases in LV filling pressure, this is really the poster child then for diastolic dysfunction. Someone who you can see up on the top hand side of this curve is a patient who has an LV filling pressure that's increased compared to the baseline example over on the left hand side. And as a result, that blue portion of the curve has now shrunk. The area in purple then is the lost supply, if you will, due to increased LV filling pressures. This is something then that, responds usually to the treatments that we offer patients who have diastolic dysfunction, diuretics, reducing afterload, treating sleep apnea, and so on. This is a really nice example from Mayo Clinic. Rick Nishimura and Blaise Carabello put this in circulation, I guess almost a decade ago now. A really nice example of a patient who, under resting conditions, has fairly normal LV filling pressures, a wedge pressure of about 13 millimeters of mercury, had a normal EF and no valve disease, but yet was coming for an evaluation of exertional dyspnea. And so they exercised this patient in the cath lab, and you can see that the wedge pressure then increases up from 13 to 41, so a marked increase in LV filling pressures. Of course, the exercise increases afterload as well, as you can see on the LV curves. And you might say, wow, there's some huge V waves on there. This patient must have developed exercise-induced mitral regurgitation or something. And that wasn't the case. They did an echo during exercise and saw that there was no MR at all. So this is simply diastolic dysfunction of the ventricle. The V waves represent high LV filling pressures. And you can understand in this patient how stress measurements would then clearly uncover that there was a large increase in LV filling pressures that shrunk diastolic supply. What about coronary disease? Well, on the right-hand side is, again, one of the classic tracings that my mentor Gould made back in the 1970s, looking at how coronary stenosis alters the pressure curve in the coronary artery. Of course, it starts off in the aorta, and in the absence of coronary disease, the pressure tracing looks largely unchanged along a normal coronary artery. But in the setting of coronary atherosclerosis, you have a loss of supply, but that loss of supply isn't equal across the cardiac cycle. The gradients during diastole are much larger. And you can see here this purple shaded area is the lost supply for atherosclerosis. And of course, the way to treat this is with statins, PCSK9, and in selected cases, revascularization. Another way that coronary arteries can reduce perfusion is through spasm. And this is a fantastic example that someone published of actually making intracoronary physiology measurements during spasm itself. So this is a case you can see over here on the right-hand side, put the wire down the LAD, and they have baseline measurements when there's not much of a gradient there at all, and gave the patient acetylcholine, and you can see the large gradient that develops really um, the coronary curve looks very ventricularized, which is what happens when you have severe coronary stenosis, either fixed like atherosclerosis, or in this case, dynamic. And so the mechanism here is vasoconstriction, and the focus is vasodilators like calcium blockers, nitroglycerin, and for patients where smoking is a trigger, they should stop smoking as well. The other mechanism, so we've talked about kind of how the floor can come up, that's LV filling pressures. We talked about how the ceiling can come down, that's coronary atherosclerosis or vasospasm, but the walls can also come in, right? Like that Star Wars movie where they get trapped in the garbage compactor. And this then is tachycardia. So you can see that on the right-hand side, this is a nice example, which I showed you earlier from Buckberg and Hoffman, of the patient who had aortic stenosis and was given isoproterenol. And you can see how the slower rate then compares with the faster rate in terms of shrinking the diastolic supply, which happens during exercise, but also other conditions of stress. And the drugs here are those who lower the heart rate, like beta blockers, nodal calcium blockers, and ivermectin. That's the supply part. So let's flip over and think about demand. So demand is largely driven by afterload, which in the vast majority of patients is a hypertensive issue, which then needs treatment with antihypertensives. But some cases, especially the tertiary referral centers, get referred for aortic stenosis or LV outflow tract obstruction that's dynamic due to hypertrophic cardiomyopathy. And those largely require mechanical treatments to relieve the fixed or dynamic obstruction. This is a fantastic tracing that brings all of those things together. This is something we published last year, which is really the combination of aortic stenosis and coronary disease creating the perfect storm for imbalancing supply and demand, especially in the subendocardium. You can see here in this patient has a severe in-stent restenosis of the right coronary artery. There's a guiding catheter up here that's measuring aortic pressures, put down a pressure wire to measure a distal coronary pressure, and then had a pigtail catheter across a stenotic aortic valve to measure LV tracings. And over on the right-hand side are three simultaneous curves. In purple, the top curve is the left ventricle. Red in the middle is the aortic pressure tracing. And the blue pressure curve towards the bottom is the coronary pressure tracing. And I'm showing you two beats to emphasize a couple different points. But first, I just want to point out to you how severe this the pathology is. You can see that the average gradient across this aortic valve, the average pressure gradient of 51 millimeters of mercury, so quite severe aortic stenosis. And then if you take a look at the pressure ratio here during hyperemia for the coronary arteries, it's 0.54. So an FFR that's also in the really severe range. So severe AS and severe coronary disease. Now on the first beat, what I've highlighted is the area for supply and demand if there were no pathology. So the area under the red curve for the aorta would be how much demand would be placed upon the LV, and then the area between the aorta and the coronary or the LV curve would be the potential supply. And you can see here that those two are relatively balanced. But both of these pathologies then twist that in completely opposite directions. The area of demand goes up quite markedly due to the aortic stenosis. And then during diastole, the pressure loss across the coronary stenosis is quite severe as well. And so we go from a ratio that is relatively balanced, maybe a ratio of 1 or so under conditions of no pathology, all the way down to a ratio that's more like 0.2 or something like that. And that, of course, then is going to explain why this patient has symptoms. It's due then to the complete loss of blood supply, largely to the subendocardial layer, given both of those items at the same time. So now that we've thought through these various mechanisms, what I want to do in the last 3 slides is cycle back to the patients whom we talked about at the beginning. This was, as you recall, a 68-year-old woman who had angina and dyspnea, had been going on for a couple years, no significant valve disease, fairly unremarkable cath down at the bottom, but yet had severe angina with diapridamol stress. And why is this happening? Well, now, of course, you know the answer. I'm bringing out 2 cross-sectional images showing you the epicardial and endocardial borders at rest and stress, and you can see that there's subendocardial shell out here and that explains then this severe angina. Again, fantastic total epicardial flow, right? 3 cc's per minute per gram. It's not an inflow problem, it's a maldistribution problem. What about the other patient, the 77-year-old who had probably myocardial injury in the setting of gallbladder surgery, but only mild coronary disease, and during diaphragmal stress had severe angina and 2 millimeters of ST segment depression. Again, it's the same mechanism I was emphasizing before. When you draw the subendocardial borders, there's almost a circumferential subendocardial perfusion defect. That's where the angina is coming from. That's where the ST segment depression is coming from. So I'd like to wrap up. This is the final slide then. What I've talked to you about is the subendocardium, why it suffers first and worst, if you will, how we can image that. Again, I've shown a lot of examples using cardiac PET, which is my own area of expertise. But as I've mentioned, there's a lot of great work going on using cardiac MRI for this as well. Interestingly, subendocardial ischemia often doesn't cause angina. That is, a lot of patients have subendocardial perfusion defects but don't have angina symptoms, although there is a dose response gradient, as you can see. But that dose response gradient emphasizes that it's fairly low risk. It's not like transmural ischemia as we see from the blue curve at the top. And then I've talked about a series of mechanisms for how supply and demand becomes out of balance, particularly for the subendocardium, and trying to link that then directly with therapy in order to modify the pathology and make patients feel better. All right, thank you so much for your attention.
Thank you very much, Dr. Johnson, for an absolutely terrific talk. At this point, I'd like to open up the floor for questions. As I mentioned before, you can either type them into the chat function or raise your hand.
I see Ed Miller's raised his hand here. I don't know how to unmute you. Maybe you can.
I can unmute myself.
There, you can do it yourself. Oh my gosh! All right. Hi, Ed. How's it going?
How are you? Great to virtually see you again, and always a wonderful talk. The physiology is really important for us to understand, and I think that I see Mehran has posted a comment. And
yes, I'll do that one maybe after your question, please.
Yeah, I think one of the questions we come across is as how loading conditions affect the physiology we see with PET. So what are you guys doing? How's your approach to loading conditions affect the measurements of myocardial flow reserve, whether it's resting heart rate, resting blood pressure, etc. And then secondly, kind of unrelated question, but kind of an interesting one, and I think people may have not really understood when you talked about it, is you measure caffeine with every test. And I think it'd be great if you could just expand on that for a little bit so people understand how you guys are doing it. It's really novel.
Yeah, thank you. Maybe I'll do the second one first since it's morning. Maybe many of you are imbibing caffeine as we speak or have already done so this morning. So we got interested in this maybe almost a decade ago now when we had a patient who had a known coronary chronic total occlusion of the right coronary artery who came for a PET scan and there was no RCA defect. I'm like, wow, he must have, just gazamba collaterals. But we checked his caffeine and it was like 1.2. And we thought, well, maybe that's it. So we brought him back after a longer period of abstinence, and his caffeine levels were then undetectable, and he had a huge RCA defect on the PET images. And we thought, wow, if we hadn't have known that this guy had a CTO and had checked the caffeine, we would have completely walked by this. And so that began a several-year odyssey of checking caffeines. Firstly, we were doing it selectively based on CFRs, but then we just decided to go whole hog and check it on everybody. And our experience is similar to a few others in the reported literature, and that's that if you check caffeine routinely, what you'll discover is that anywhere from 5 to 20% of patients have caffeine at the time of vasodilator stress. And it is due to a combination of reasons. Of course, some people are just non-compliant. Some people are taking maybe medicines that they don't realize have it, or they think that the decaf stuff has no caffeine in it. But some people are honestly slow metabolizers. I have one person who I have really good documentation on him when even after 72 hours, he still had residual serum caffeine despite being off caffeine completely. So some people, due to a combination of factors largely processed through the liver, have slow processing of their caffeine. Their Starbucks lasts them for days. And what you see there is that it will absolutely blunt the flows that you measure. It's a competitive antagonist for all of our vasodilator drugs that we use in the nuclear lab. And as a result, you can have both false negatives and false positives. And so as a result of that, our policy for many years now has been to measure caffeine routinely. Of course, it doesn't come back immediately. It comes back a day or so later, but it allows us then to call certain patients back for redo studies with longer periods of abstinence. And we do that occasionally. I'd say that's a minority of things, but when it does happen, it in some cases has really changed our clinical interpretation. The second question you were talking about is loading conditions. And this comes down to, I think, this notion of, should we try to adjust the resting perfusion that we measure for the observed pressure rate product? For example, someone comes in and maybe they're a little nervous and their blood pressures, or they didn't take their meds that morning and their blood pressure is 180 and their heart rate's 90 when they're on the PET table, and we take their resting pictures, right? And you may ask, well, is that really a valid representation for that person? Maybe when she's at home and the blood pressure is 110 and the pulse is 60, the resting perfusion would be quite different. So perhaps we should take this pressure rate product into account and modify our measurements of resting perfusion, or then coronary flow reserve. And I'll tell you that pressure rate product, because we've looked into this, actually there's this kind of JACC state-of-the-art review that hopefully is in its last stages and it will come out soon. But when we look at pressure rate product, it probably explains maybe a third or so of variation in observed perfusion. And there are many other factors that also affect resting perfusion. Women tend to have higher resting perfusions for reasons that we don't fully understand. Patients who have chronic kidney disease or end-stage renal disease have higher resting perfusions. Body habitus, actually, larger people have lower resting perfusions. And so our policy has been to not fudge the numbers, if you will. That is, if you observe a resting perfusion of 1.2 cc's per minute per gram, that's what it was when you measured it. And that building complex multivariable models, which you would need to do because resting pressure rate product is not the only game in town, can only account for about half of that population difference. And so that tends to not be a very productive way of approaching it. We think that the far better way of doing this is looking at both stress perfusion, that is the cc's per minute per gram that you measure under hyperemic conditions, and coronary flow reserve together. And by combining those two into a metric called coronary flow capacity, that also adjusts for some of these notions of loading conditions as you bring up. I see Dr. Zaret has a comment. Maybe I'll just talk about one or two of these ones that people have typed into the to the chat box. I'll read one of them out and then we can have a bit more questions from the group. So the first one is the effect of heart rate changes on the apparent rest and stress LV cavity sizes. And the second question then is about how the rubidium path length of the tracer allows you to distinguish things. So for the first part, is you're absolutely right, is the heart rate is in some ways the elephant in the room for perfusion imaging. One of the reasons that stress images often look better, not only do we, in the SPECT world anyway, use large amounts of tracer for low dose, high dose protocols, is that patients are more tachycardic. And so the heart spends more of its time in systole, and so therefore the myocardium is thicker on average, and so you have better count recovery because you're not imaging as small a target, so you have less partial volume loss. And that certainly is an effect for the PET images as well. And so what we've done to take that into account is to understand in the normal volunteers what the limits are for kind of normal people and use that as our benchmark for pathology. So that's our way of adjusting for or taking into account this effect of heart rate. As far as the positron range goes, that too had been an initial concern of ours, that rubidium would really be so blurry as to not be able to see these subendocardial perfusion defects. But as you can see from the data I've presented here, I think that you can get an understanding of that. And I would say that actually the much larger issue usually is the point spread function of the imaging system yourself. And the way to take our concept that we've developed so far, I think, to the next level would be to develop these kind of, if you will, constrained deconvolution methods of understanding how the image tracer then corresponds to the true tracer as modified by positron range and then also by the point spread function of the imaging system. Maybe Dr. Zaret, I think you were raising your hand. I saw a hand go up. Am I right? Maybe to take yourself off mute and ask away.
Well, thank you for a wonderful talk. It was Great to also see Julian Hoffman's classic work of the early 70s when I was just starting, and followed very closely that it's being resurrected for good purpose. I have a clinical and a technical question. Clinically, we've always taught that pharmacologic induced steel its major correlate is multi-vessel disease with significant epicardial collaterals. You have a very large database of patients with this phenomenon, more than I think we've seen or I've seen over the years in a clinical laboratory. Have you seen that anatomic correlate? That's clinically. And technically, I'm interested in some of the issues that you alluded to in terms of resolution and dealing with equipment across a relatively small area of myocardial thickness. And do you notice any difference in reproducibility, reliability, et cetera, in non-hypertrophied versus hypertrophied ventricles in the patients you've looked at?
It's a good question. Maybe I'll talk a bit about the technical piece first. The one of the absolute, like if you go back to this group in our tree of patients who have good transmural flows and no subendocardial defect, but yet have symptoms, right? This group over here that I'm highlighting in purple. Mm-hmm. It's not this, yeah, it's this group over here. And you can see that some of them do have angina and ST segment changes. They don't have obvious subendocardial perfusion defects. Why is this happening? It turns out when you look at those patients, that they tend to be patients who have a smaller body surface area. And it is I think, a very great hypothesis that we have as well, that potentially in those patients, the heart is simply too small for you to see the subendocardium, given the limitations of PET that other people have brought up. And so it could be actually that almost everyone has a flow mechanism for diprotomol-induced angina ST segment changes. In some patients, you aren't able to see it because the person is too small and the heart's too small. But if that, kind of whatever 50-kilogram woman could become a huge NFL linebacker, yeah, then you'd see it. Just you aren't able to for the technical reasons that you bring up. And then, sorry, just remind me of your clinical question that you started off with.
The question is the anatomic correlates
of steel, right? And so I guess I would distinguish between two types of steel. There's a real big transmural steel, like this patient who had the RCA lesion who I began with. These kind of patients have huge, big, bad perfusion defects, and they have really critical coronary disease that's collateral dependent. And so this type of vessel, although not technically a chronic total occlusion, because you do see some antegrade flow there, is a functional chronic total occlusion. It's collateral dependent myocardium. And that's what induces the steel in this particular case. So this type of steel is almost always associated with severe collateral dependent epicardial disease. In some cases, you can get it if you have very severe serial diffuse disease in a branching coronary tree, and by the time you get out to the apex, you can also see, like, you have one of these LADs that just chocked full of cholesterol and every branch is horribly diseased, and by the time you get to the apex, essentially you're collateral dependent, if you will. There's also this notion then, as you recall from Buckberg and Hoffman, about intramyocardial steel, this notion then that the subepicardium steals, if you will, from the subendocardium. And I dislike the term steal as a misnomer. There's actually no stealing going on. The way I describe it is that if, let's say, someone is poor and living off government handouts, right, and we go into recession and the government handouts get cut in half, it's not that the government is stealing from poor people, right? They just aren't giving the size of the handout that they used to. And the same thing happens here across the layers. It's not that the blood is stolen away from the subendocardium, it's just that the flow to that innermost layer drops. And so that's something that can happen, as I've shown in many examples in this particular talk, in the absence of epicardial disease. I mean, think about this woman back here who had the angiogram, right? This patient over here is not someone who's stealing out of the subendocardium because of critical epicardial coronary disease. What's happening here is that combination of factors has imbalanced the Buckberg index, if you will. The patient has hypertension, the patient is obese, probably high LV filling pressures, tachycardia that develops when the patient is walking after a block. All of those factors then serve to cut blood flow off to the subendocardium, and that's where the symptoms come from, even in the absence of critical epicardial coronary disease.
Thank you.
I'd like to address maybe a comment here that Dr. Shaw typed in. It's talking about the role of subendocardial ischemia in patients who have heart failure, preserved EF. And I think that comment is so great because of this person. I mean, think about this 60-year-old woman has exertional dyspnea in the absence of critical coronary disease, and the EF is 60%. Does this patient have heart failure with preserved EF? I think a lot of us would classify it as heart failure preserved EF. It's a term I personally dislike. I think that history is not going to look kindly on us for developing that notion. I would be much more basic about this. I think this patient has diastolic dysfunction. That's why the patient has exertional dyspnea. And so for that subset of heart failure preserved EF where it's due to diastolic dysfunction, that's absolutely then what's going on with these patients. When she walks a block, that's what happens to her subendocardium over there. That's why she gets dyspneic. And so I think that is absolutely a very clear pathophysiologic link between the two. Dr. Sunesis, I think I saw your hand raised there, please.
Yeah, great talk. I agree with you. I think we misunderstand what's going on physiologically, not being able to assess endo-epi ratios and sort of your approach in looking at systolic and time intervals, I think is also kind of novel and important. The question I have is, people raise the issue of the tracers, but I think also, as you alluded to, the partial volume effects are important, and one would really have to consider what the resolution of the camera is, and with the new digital PET, maybe we're at a better shot at getting these endo-epi ratios. The other comment I would say is that we found to really accurately assess regional flows, you need to do respiratory motion correction. And I was wondering whether or not you've found that, or you've implemented respiratory motion correction in your analysis of the PETs.
It's a great point. Just last week we got a United imaging camera installed here, and we're just about to kick out our old Discovery ST system and replace it with a new GE system later this year. So I too am excited about some of the new solid state detectors and what they have to offer. And as we brought up before, it could be that some of these cases where you don't see the subendocardial shell out and you think, oh, it must be some other mechanism. Maybe they are actually having the same thing and you just can't see it. As far as respiratory gating, we spent a fair amount of time on this. One of the nuclear physicists down the street at MD Anderson has a real interest in respiratory gating, and we haven't found that to be really important for getting good quality perfusion images. We found that the much more important piece is having a CT PET co-registration. And so we're much more obsessed with getting 2 CT images for each case. We do a standard helical, and then we also do a free breathing, almost 90-second CT image in order to try to really simulate attenuation correction in conditions that are similar to what's happening during myocardial perfusion during the PET part. So we think that respiratory gating, in some cases, of course, it can really make a profound difference, but often that issue is more linked with having adequate attenuation correction CT images, which is solved in one way technically by doing this kind of long free breathing sequences. Well, here I see it's 8 o'clock on my watch. I see a few other people typing comments. I don't want to hold everyone back from going about real work or whatever it is you do. I'm happy to stay and answer a few more questions if people have time for it, but I know sometimes there's a hard stop at 8 o'clock here, 9 o'clock for you guys. Should I do a few more of the comments that people have typed into the chat, or is there a...
Yeah,
okay.
why don't you can take the last couple of questions in the chat. If folks need to drop off, then certainly they should take on their next activity. But I think that the questions that are put in there are terrific, and a lot of people enjoy the answers if they have time to stay on. So. Agreed.
So Dr. Sufer is asking the question about the biologic endpoint for microvascular dysfunction. And it's a great point. And I'll just come back to this flow tree and to bring up that microvascular angina is really rare. I mean, we're a tertiary referral center that does all kinds of research protocols on tough patients. And you can see in our database that there may be 6 people that you might say have microvascular angina. So I would first just reiterate that message that largely when people have said microvascular angina, it's probably because the imaging tools weren't able to understand that mostly what's happening is subendocardial hypoperfusion. And so in that sense, then, one of exclusion is probably in some ways the right way to think about it, but just from an epidemiologic pretest probability point of view, when someone comes and has angina but doesn't have a big bad transmural perfusion defect like that RCA case I showed, the dominant mechanism is subendocardial hypoperfusion due to all of the factors that I mentioned that tend to imbalance the supply-demand metric. And so I almost would start with that as my working diagnosis. And for the rare patients who don't have that, then yeah, microvascular angina is the issue, but quite uncommon. The last question then is talking about true endothelial dysfunction, for example, bioavailable NO defects in the absence of flow-limiting epicardial atherosclerotic disease affect the subendocardial microvessels to a greater extent. This could be relevant in younger individuals who have systemic inflammatory diseases or patients who have normal lipid levels, but other markers of inflammation like high CRPs. And yeah, I think that small group of patients absolutely could probably be characterized. And you might ask the question, why do they have such severe endothelial dysfunction? And it's a potpourri. Among that group of patients, we've had those who have been on, say, chemotherapy treatment, right? Chemotherapy treatment can really knock out your endothelium and produce really this global reduction in coronary flow reserve. And therefore, you have a low CFR, and things tend not to go well clinically for those kind of patients. But it's often, in some cases, then a secondary phenomenon to other stuff. Whereas you bring up, there might be some systemic inflammatory diseases that are producing a similar component. And so I agree with that. I think that those are important to understand for that group of patients who doesn't have a subendocardial perfusion defect. The subendocardial perfusion defects, though, aren't driven by those other factors. They're largely driven by hemodynamic forces that imbalance subendocardial supply versus demand, as I outlined with the kind of Buchberg rubric.
Thank you very much, Dr. Johnson, for a thought-provoking, detailed, and nuanced talk. And thank you for everybody who stuck around for a few extra minutes. And look forward to seeing everyone back next week. Thank you very much, everyone.
Enjoy the snow, everybody.